Okay, so now we're going to talk about surgical management or post-operative care of both the lobectomy and the wedge resection, because post-operative care is very similar. Both of these surgeries would require a closed chest drainage system or a chest tube after surgery to drain both air and blood that collect in the pleural space and allow for chest re-expansion. Nursing priorities are to ensure the integrity of the system, promote comfort, make sure that the chest tube stays patent, and to prevent complications. Okay, I want you to look at chart 30-12. When you look at chest tube placement, see how the air drainage tube is up much higher under the axilla, where the blood drainage tube is below the incision and lower because gravity will pull the blood lower down onto that chest tube. So you can see that they'll usually have both an air drainage tube and a blood drainage tube. Now that doesn't mean that blood doesn't come out of the air tube and air doesn't come out of the blood tube, but that's the reasoning for having the two tubes, is so that the drainage can be taken out of the pleural space. As far as chest tubes go, for testing purposes, as long as you're familiar with chart 30-12 and the slides here today, you will learn more about chest tubes and their care when you are in lab with Ms. Stone. Now, on to postoperative care. All three surgeries would require pain management, which is usually done with a PCA and opioid analgesic. You also have to have respiratory management. You have to maintain a patent airway. A lot of times these patients are on ventilator support for usually about 24 hours. You have to make sure that you're monitoring the amount of fluid coming out of the chest tubes at least every 2 hours. You also want to make sure that you're managing and checking their lung sounds at that 2-hour mark as well. You want to make sure you're not having too much drainage. You want to make sure the drainage hasn't stopped. You just have to keep a good eye on the drainage. Usually the physician will tell you and will write an order that says, notify me if drainage is less than blah, or notify me if drainage is less than whatever the number might be. So, but it's important that we assess that at least every 2 hours. And then pulmonary toilet is every hour while awake. And we discussed what pulmonary toilet was with our last lecture, and that's the turn, cough, deep breathe, making sure that the patient is being able to clear those upper airways so that secretions do not gather in those in the lower lung fields. Remember, we've already talked about pneumonectomy care being a little bit different than the lobectomy care. Up to this point, other than the chest tube, all of that is still pertinent with the pneumonectomy. They need pain management. You have to manage their respiratory system. You have to make sure they have a patent airway. They're usually ventilated. You have to prevent complications. They also need pulmonary toilet, which is every 1 hour while awake, which is the current turn, cough, and deep breathe to keep secretions from going into that remaining lung. Other pneumonectomy care complications are the empyema, which we've already discussed, and the bronchopleural fistulas. And remember, positioning is a surgeon's preference. And I'm not even going to try to guess it because, like I said, I've worked with 2 thoracic surgeons, and they both had entirely different views on how the patient should be positioned. So look at the physician's orders and go from there. Like we discussed earlier in the lecture, a lot of times lung cancer is diagnosed late because that is when it becomes symptomatic. So a lot of these patients have a less than 16% survival rate for 5 years and choose to go under palliative care. Now, with palliative care, it doesn't mean that they're not treated, but they are treated to provide comfort and to keep their life where they want it to be, to give their what's remaining of their life the best possible outcome. Does that make sense? We're no longer looking at curative. We are looking at, I'm only going to, hopefully I will get to live around 5 years. I want the doctors to help me, but I know I'm not curative. So what I want is to be comfortable and as symptomatic free as possible during this period of time. So, what are some things that we look at for palliative care? Well, a lot of times these patients require oxygen therapy because of hypoxia. Drug therapies include bronchodilators, corticosteroids, and mucolytics to help to clear the secretions from the lung fields. A lot of times patients under palliative care will still have radiation therapy because it sometimes will relieve the hemoptysis or of the obstruction that perhaps is making it to where they're having difficulty breathing, or it will help to relieve some of the dysphagia so that the patient can swallow more completely if the tumor is affecting that. So radiation therapy is given to patients in palliative care. Sometimes these patients will gather a lot of extra fluid from having the lung cancer. And so a thoracentesis, where the pleural effusions are temporarily drained. Now the fluid will build back, but this temporary relieving of the pleural effusion will relieve some of the hypoxia. It also helps with dyspnea management, which we talked about as far as with dyspnea management, which is shortness of breath. We usually will use oxygen. Morphine helps not only with pain, but it also helps with respirations. And we also will talk about different ways to position the patient so that they will have less shortness of breath. We also, with palliative care, will take care of pain management. Usually, the drug of choice will be morphine because it is dual purposed. The morphine, being an opioid, helps both with respiratory shortness of breath and with the pain caused from the lung cancer. I hope that makes sense. Now, remember the big difference between palliative care and hospice is palliative care, means that the patient is no longer seeking curative care, but is hoping to lead the best life possible for the length of time they have left. The change to hospice is for the patient who is dying and who that we are assuming will have less than 6 months to live. On a personal note that, of course, will not be on your exam, in my lifetimes, I have worked as an ICU nurse and cared for the patient who chose to have a pneumonectomy or a lobectomy, and cared for them on the ventilator, had difficulty getting them off the ventilator. They had a lot of pain with the chest tubes. When I was working in ICU, it was very limiting as far as family visiting. And then I also worked at hospice where these patients are cared for with morphine and with radiation therapy. I never understood why radiation therapy was still given to hospice patients, but it makes a huge difference sometimes, especially when they're having a lot of shortness of breath and difficulty swallowing. Because a lot of times these patients will have trouble swallowing, but they're still experiencing hunger. And that's so sad when they can't eat, but they want to eat, but they're not able to. And so that's one of the things that radiation therapy for both palliative and hospice care can assist with. Pain management is very important for both of these patients. I don't know which way I would go with it, but a lung cancer patient, whether you're taking care of them in an acute setting, such as in an ICU, a surgical ICU, or at home in a palliative care or hospice setting, are a challenge for the nurse to care for. And that's important for us to know that it can be very challenging to keep comfortable and to give them the best outcome that they can have. And that's it.